Everyone. Myself, Dr. Mahesh Chaudhary, third year radiology resident in New Civil Hospital, Surat. Today, I will present a paper on the topic of role of radiological imaging in cerebral hydrated disease. I especially thank my co-author and my PG guide, Dr. Purvi Desai, professor and head of radiology department in New Civil Hospital, Surat. Introduction. This is the parasitic infection which caused by tapeworm larva of two Echinococcus coccus species, Echinococcus granulosus and Echinococcus multilocularis. The epidemiology: this disease is especially endemic in Middle East, South America, and Australia. It is important this condition also seen in non-endemic area because of migration of human groups from the endemic to the non-endemic areas. It's primarily occur in the liver and lung, and CNS involvement is rare and seen in only 3% cases. The pathogenesis are dogs are definitive host and sheep are intermediate host, and human are infected only by the accidental ingestion of the food and water which is contaminated by the ova of the tapeworm. Clinical features: it's mainly asymptomatic and symptoms are caused by mainly compression effect. The main symptoms are the headache, nausea, vomiting, and seizures. The diagnosis of hydatids is made on the serological test and imaging technique. Imaging features are neuroimaging of hydrated disease characterized by well-defined oval mass in the brain tissue, which often seen in the middle cerebral artery territory due to its embolic nature. On the CT, it shows well-defined affluent density lesion with isotohyperdense thin wall. On MR, there is two variant. One first is cystic echinococcus, which caused mainly by the echinococcus granulosus. This is more common variant and demonstrate internal fluid intensity which is similar to CSF on all sequences with smooth, thin, well-defined hypointense wall both on T1 and T2. There is usually no enhancement, no surrounding edema, rarely calcification, and daughter cysts may be seen. Multiple cysts are rare and result from the rupture of the primary solitary cystic lesion. Alveolar echinococcus is mainly caused by Echinococcus multilocularis. It is rare and on imaging it's mimicking the malignancy. The lesion demonstrates a semi-solid structure with multiple vesicles in a dense connective tissue stroma. Calcification and surrounding edema are frequently seen in this condition. The aim and objective of my paper is to describe the characteristic feature of the cerebral hydrated disease on CT and MR. Early diagnosis will help in early intervention and treatment, which will improve the patient prognosis. The methods: I took total 4 patients with cerebral hydrated disease, which were imaged at our institution. Both the findings of CT and MR are retrospectively evaluated. The CT examination were performed on two CT scanner. First is Wipro and second one Philips, and MR examination were performed on Siemens 1.5 Tesla machine. Now case first: 63-year-old male patient present with complaint of change in voice and deviation of mouth. On the plain CT, brain showed well-defined hypodense lesion with hyperdense rim and surrounding edema, vasogenic edema. On MR images, on the T1 axial section, there is hypointense lesion with thin internal septation. On T2 axial, we can see the hyperintense lesion with internal septation with surrounding vasogenic edema. On diffusion restriction, there is no diffusion restriction is seen. On post contrast image, there is thin rim enhancement maybe is seen. Case 2, a 18-year-old boy present with headache, nausea, and vomiting. On plain CT, there is hypodense lesion with hyperdense septation, which can be seen here. On T1 axial section, there is hypointense lesion with hyperintense septation. On T2 axial section, we can see the hyperintense lesion with thin hypointense septation is seen. And post contrast, we can see here is a partial ring enhancement will be seen on the its medial aspect, and we can see the mass effect which shifting the which crossing the midline, and there is also mid mass effect which is causing the midline shift. Now, case 3, a 42-year-old male patient presenting with headache. On T1 axial section, we can see hypointense lesion with internal septation, and similarly on T2, there is hyperintense lesion with internal septation. On post contrast, there is no enhancement. On diffusion weighted imaging, there is no diffusion restriction. In case 4, similarly, we can see that on T1 there is a hypointense, on T2 there is hyperintense lesion, on post contrast there is no contrast enhancement, on diffusion weighted there is no diffusion restriction. The treatment is mainly surgical. The surgery is most effective treatment, but During surgery, their integrity of walls should be maintained to prevent any anaphylactic reaction. Treatment with drugs also seen effective, but data available is limited. The results, the CT and MR in combination will helpful in diagnosis cerebral hydrated disease. On the CT is superior in detecting calcification of the cyst and cyst wall and septa. MR is better in characterizing the lesion and defining the anatomical relationship. When a well-defined spherical cystic and intracerebral lesion with obvious mass effect but no edema, no enhancement on CT/MR seen, hydrated disease should be taken into consideration. If perilous edema or remanagement is seen, it can be seen in a complicated hydrated cyst or other cystic lesion of the brain should be considered in the differential diagnosis. Now the discussion. The cerebral hydrated cysts are usually benign and slow growing cysts. The lesion may remain asymptomatic till they are quite large and can clinically manifested in form of the headache or vomiting. The lesion of the cerebral hydrated disease usually is distributed in the territory of middle cerebral artery due to its embolic nature, especially in the parietal lobe. The most cysts are located in supratentorial lesion. Multiple cerebral hydrated cysts are rare and result from spontaneous traumatic or surgical rupture of the solitary primary cyst. Patients with cerebral hydrated cyst may have cyst in other organs, so they should be screened for that. Both CT and MR demonstrate a spherical, well-defined, smooth, thin-walled, homogeneous cystic lesion with fluid density similar to CSF, with or without internal septation or wall calcification. The cyst wall usually showed a rim of the low signal intensity both on T1 and T2 weighted images. The presence of daughter cyst is pathognomic, but it's rare. The compression of midline structure is usually seen and edema and remanagement is usually absent. The cerebral alveolar echinococcosis are rare, and on CT and MR it shows as a solid, semi-solid, or multilocular cystic mass with definite margin, and calcification surrounding edema are common. And contrast enhancement also seen in surrounding region. Now, if my differential diagnosis for that is first is porencephalonic cyst, but in porencephalonic cyst there should be past history of vascular insult to brain. A second one is arachnoid. It is extraaxial lesion and shows a mass effect with no enhancement. Other cystic lesion of the cystic tumors of brain can be seen like cystic glioblastoma, but in this there is diffusion restriction seen and there is mark enhancement will be seen and indistinct margin will be seen. The fourth one is pyogenic abscess. In the diffusion restriction will be seen and peripheral rim enhancement will be seen. Other fifth differential is cystic metastasis to brain. It was seen in condition like lung carcinoma, renal cell carcinoma. So there should be history of primary. Then we can suspect this also. This is my references. Thank you.